Good afternoon. Thank you for your time and attention today as we provide the COVID-19 situational report with an update on vaccine rollout. And Max, whenever you're ready, thank you so much. So we'll begin with how many cases and other indicators, those indicators that we've been looking at. And as of today, okay. Thank you, sir. So as of today, we've identified 12,040 confirmed cases in Buncombe County since the pandemic start. 230 COVID-19 deaths have been identified, and our current new cases per 100,000 per week is 368. And now that is actually down from the previous week. After several weeks of consistently increasing percent positivity, locally we are seeing our first week of significant decrease in the number of tests that are coming back positive. Our current percent positivity is 9.5%, and while this is still far from the desired 5% or less, it is a welcomed improvement from the 12.5% we experienced not quite 2 weeks ago. Regional hospitalization data continues to show what appears to be what I called a high-level plateau last week. There was a slight dip in the hospitalizations about a week ago, but now you can see again that stabilization and high-level plateau. Our current metrics have shown some improvements since last week, and currently, as I mentioned, the new cases per 100,000 remains high, but we did see that decrease, and these are the numbers as of today. Since the state did not update the dashboard yesterday, I went ahead and pulled them for you today, so you had the most recent. New cases per 100,000 population did decrease in the last week, but it still remains high. You can still see that in the red. In the 2 weeks prior, we were noticing that slowing of the rate of the increase in those new cases per 100,000 with another, another high level plateauing. This week, we actually are seeing a slight decline in that indicator, still in the red, but when we look at the derived indicator from change in new cases per 100,000 population from week to week, that indicator is actually coming into the yellow, so we did see a decrease. We saw the percent positivity, as I mentioned earlier, decline this week. I'm sorry, that should say 9.5, the percent positivity, which would still put us in the orange. And then the change in test positivity from week to week also showed a favorable decline, so putting us in the green. And so again, this is just the first week where we are seeing that significant decrease in percent positivity. The deaths per 100,000 population per week is at 9.1, which is still red, but we again saw in the derived indicator from change in week to week, we saw that go down in a favorable direction. The hospital data continues to be stable for the second week in a row. There was not a significant change in the percent inpatient hospital beds occupied by COVID-19, nor was there a significant change in the percent ICU beds occupied by COVID-19. I did want to take a bit of a deeper dive into the indicators, given that you are set to review restrictions placed that were effective January 2nd. And I thought it might be more helpful to sort of look at those in particular. So the first is the current epi curve for Buncombe County. You can clearly see the post-Thanksgiving surge that continued into the December holidays. And following that surge in the recent days, this is where we can start to see that high-level plateau emerge, that if we were to draw a trend line there, that we would start to see that very high, but start to level out just a bit. I did want to make note of the percent change in new cases per 100,000 per week. I mentioned this earlier. When we look at the percent change in new cases per 100,000 per week, we can see an overall decrease since December 22nd. And this is indicative of that slowing of the cases, new cases that I mentioned earlier. And while they remain high, there is some early indication, particularly this week, with a decrease in new cases per 100,000 per week of a plateau. Still too early to say that we're coming down from the surge, but looks like we might be staying at a high level with slowing of the increases. And then when we look at the percent positivity deeper dive, we can see here that the percent positivity increased significantly just before the new year. We were seeing like the increase start with its highest rates right there in early January. So when we looked at right before Christmas, we were seeing our 8.2%, and that had a steady incline until just about right before New Year's, where we saw it increase significantly. And now we've started to see that come down as we've entered the post-holidays. And as I mentioned earlier, our current rate is about 9.5%. This is the first week over week that we've seen a significant decrease. Last week when I reported to you, it was still 11.7, which was a change from 10.5, I believe, the week before that. But in between that 10.5 and that 11.7, it had gotten as high as 12.5. So this is the first week-to-week change where we've seen a significant decrease in the percent positivity. And then when we look at the hospitalizations, and this is the inpatient census, the blue line is system-wide for HCA, and then the orange is just mission-specific. And you can see these are parallel and very similar in their trends. But what I'm looking at right now is right before the holidays, we were seeing that at a fairly high level. It increased and was at a very high level just around the beginning of January with a small dip, and now we start to see that, again, still at a high level, plateauing or straightening out a little bit. So with that, that concludes the situational report regarding the indicators. We wanted to provide you a little bit more detailed information about those as a board, as you review and reflect on the restrictions. So indicators are showing some improvements for the first time in many weeks. We typically pull this data on Mondays and are able to provide you another data point on January 25th if it pleases the board in order to make a decision. And if you'd like me to continue, I'll go into vaccine rollout.
Thank you so much, Stacy. And it's good to hear some positive news, even though it's in the context of an awful lot of COVID transmission and sickness occurring in the community. At least it's not growing in the way that we saw it at the end of the year and the beginning of 2021. So that's great to hear. So just to maybe just kind of summarize what I'm hearing in terms of the process. So the health team kind of reviews all the data on Mondays each week. So you'd like to have this additional week to review the numbers coming in this week, to confirm that the trends of stabilization and hopefully continued improvements, to see that those trends do continue out and look a little more firm. And you could review the data on Monday next week, and if they continue to look positive, that would give some reassurance that the threat of the hospital really being seriously overrun appears to be diminished compared to where we were in December when we adopted the indoor dining policy, and could potentially consider using the state policy going forward if the data continues to look stable or improved.
Yes, I think one more data point would give us a little bit more information about, especially given that this is the first week that we've seen some of those indicators really decrease versus stay stable.
Okay, so that review would be on Monday the 25th. And if it looks positive, then we could consider going ahead and making the decision at that time to go with the state policy. And the commission also has a meeting the following day too. So if we, I mean, of course, so I could use my authority to go to the state policy, or the commission can meet the next day. So if we could also have a commission discussion about it at that meeting as well, if we desire to. Commissioners, are there any questions or? All right, I think we're good on, thank you for the updates,
Okay.
and we'll hope for continued good news and continue to ask for the community support in keeping these numbers going in a more positive direction, and hopefully that'll allow us to make a decision next week that I know a lot of folks would like to have us do in terms of the restrictions policy on indoor dining. So, all right, Stacey, what's next?
All right, so
So
on to
before we move
vaccine.
on, sir, will we put this on the agenda on the 26th, or with that Tuesday special meeting? Just go ahead and add this to the agenda.
So we should definitely have an update at that meeting, I think, regardless. So that sounds good to me. I mean, I would say, you know, yeah, let's plan on doing that.
Ready for me to
Sure.
continue?
Yep.
So just a reminder that the North Carolina Department of Health and Human Services did change their prioritization plan on January 14th to align with the federal administration recommendations. This change went into effect January 15th. This change did come as locally we had already implemented and scheduled our appointments under the previous iteration of the vaccine prioritization. So we will begin really incorporating the new phases, which were really just amended phases, at the end of this week and beginning next week. And so just as a reminder, aligning to the federal recommendations, the first group 1, what they're calling now, so they collapsed many of those subgroups that we were seeing prior. And group 1 now is healthcare workers and long-term care facility staff and residents, with group 2 being 65 years and older. And so I just wanted to give a reminder from last week that shipment about vaccine and how that occurs, that we typically receive our notification of shipment on a Friday, with the actual vaccine arriving Tuesday afternoon or early on Wednesday. And the vaccine that arrives on the Wednesday is used typically to finish out that week and to make sure that we have enough vaccine for the appointments that we have promised at the beginning of the week until the new vaccine shipment comes in. So typically a Wednesday to Tuesday type of process. And I just wanted to put out, make sure that folks are aware that Public Health has advocated for additional doses and has been working with both state and local partners to get more vaccine into our community. This includes working with the Western North Carolina Regional Collaborative, which is state and local partnerships that include other health departments, community health centers, and hospitals in our Western North Carolina area. And as a part of that collaborative, Buncombe County Health and Human Services received an additional 500 doses last week that were able to expand our available appointments this week. And our colleagues in Madison County also received a bump in vaccine and have expanded their mass vaccination reach as well. And one of the tenets of the collaborative was to have community health centers come on board as well. And the first one to do that in our region was Blue Ridge, who also received vaccine and is working to start up their vaccination efforts. So this is good news that we are starting to see more providers, though slowly. We're seeing more providers get enrolled. We are looking forward to having 2 other community health centers anticipated this week, which would be Winches and Appalachian Health. It is expected that they will be receiving small vaccine allotments, and in anticipation of their onboarding, we actually invited Winches to come shadow our vaccination site so that they could get an understanding of flow, like how does the clinic flow, what are the operations like, what are best practices. And then leading into that, I just wanted to share that in addition to the collaborative, Health and Human Services has worked with Mission Health to initiate vaccine transfer to increase the number of vaccine that we can get out into the community. And what you see here is our inventory of first dose, what it looked like earlier today. You will see that the shipment that came in today is not on here yet because it came in after this was created. So what you're seeing is current inventory of first dose, and you can see our first 3 shipments, 12/21, 12/30, and 1/5, have all been depleted. We are currently working on that 4th shipment there, and it is on its way to be depleted today, probably already is by the time I'm talking, and have moved into our bump from last week and soon to move into our transfer from Mission, likely today or early tomorrow. And I wanted to also state that we did receive our notification last Friday of what we would receive this week. Our regular doses of 975 Pfizer are coming to us, and another 500 bump from the Western North Carolina collaborative that we're doing as a region. That arrived, at least one of those arrived today, and we will be working to utilize that 500 Moderna doses as that bump to help expand our reach into healthcare workers and utilize our 40 Cox site for that. So while still limited, that's, we're grateful for whatever amounts that we get in addition to our regular shipment. They are still very limited, but do allow us to improve and sort of allow us to increase our appointments. I did want to.
Stacy, or
I'm sorry.
Go ahead. So this number on the shelf, 12/21, 12/30, and 1/5, that means that they have received their second dose now. Them was the ones put back.
No, what you're seeing here is the number. These are all first dose. So of the shipment we received 12/21, we received 700 doses of Moderna. Each one of those vials, sometimes you can get an extra dose out of. So we actually administered 712 doses to people. This is all their first dose. There are no more of that shipment on the shelf. And then going forward, the second shipment, we received 975 of Pfizer. We were actually able to get a few more doses out of each one of those vials, and we're able to actually administer 1,112. There are no more of that shipment on the shelf. So we have depleted our first 3 shipments and are moving into the later shipments. I don't have second dose on here yet because those just came, and we're starting to get people their second dose that were in the old version of Phase 1A, which were medical first responders, healthcare workers critical to COVID-19 care, and long-term care facility staff and residents. So those first folks that we did that week of Christmas and the week of New Year's are just now getting their second doses.
So that, does that mean that the supply, and I'm sorry, Parker, we'll come right back to you. Does that mean that the 975 and the 500 that we now have or will soon have, some percentage of those will be used for second vaccinations?
No, we have a separate allocation of second doses. Right now, the state is still sending designated second doses that match your first dose allocation. So we received our second doses, which would have been 700 of Moderna and 975 of Pfizer. You're not seeing that here. This is all first dose because we just started second doses.
And what's the supply of second doses we have on hand?
So it would be 700. We received 700 Moderna. It will match the first 2 shipments that you receive up there. 700 Moderna, 975 Pfizer. But we started giving folks their vaccines this week, and so I do not have a good number for that one today, but by next week. Okay,
and I'm sorry. I know you've said this. I'm just trying to make sure I'm hearing it correctly. So the numbers on this chart, on this slide, don't reflect the additional vaccines that we have for vaccine number 2 for
It does not.
Okay.
This is all first dose.
Got it.
All first dose.
Got it. Parker.
You gave me a second question to ask, which is that I understand these vials sometimes have extra vaccine in them. So how does it work with the second dose when we're getting the standard quantity shipped to us?
Very good question. So we have to be very careful and make sure that we are as careful drawing up the second doses as we were the first, so that we can get those additional doses out of them. So that is absolutely at the forefront of our minds, and our nurses and pharmacists who are drawing that up, that you have to be very careful. You have to know what you gave the first time, and make sure that you're drawing up just as much.
Okay. And then my question from before, I guess briefly, can you explain to us that this WNC collaborative in terms of where those extra, again in air quotes, vaccines are coming from? Are they from one place? Is it a collection of?
So my understanding of the first week was you all had asked about the federal program to vaccinate long-term care facilities with CVS and Walgreens. And last week I had mentioned that they had received, I believe, 169,000 doses, but had only given out about 40,000 at that time. So the state suspended their allocations, and that suspension allowed for other parts of our state to get those doses. So that's where that first bump came from. I think that's where the second bump is coming from, because they suspended it for a second week to allow those CVS and Walgreens to start using the doses that were on their shelf. So we as the Western North Carolina Collaborative got some of those doses. Some hospital systems got some of those doses in the Triad and Triangle to do different types of events.
Okay. Well, it sounds like maybe we should come back to talk about the drugstore situation, but I think what I heard you say is that despite it being a federal program, the state of North Carolina is responsible for shipping the vaccines to CVS and Walgreens. Is that correct?
They are responsible for allocating to them. So the federal government tells the state of North Carolina, you get X amount of doses. Off the top of that allotment to North Carolina has to go the long-term care facility federal program, and then the rest is distributed throughout the state. So the state has indicated to the federal government that they would suspend that allocation to the long-term care facility federal programs, as they have many doses on their shelves and have not vaccinated all their doses yet.
Thank you. I'll stop asking.
So I do have one follow-up question. In terms of, so the state is informed how many vaccines will come to our state, and then they have an allocation process for our state. In terms of how things are distributed, are they distributed to a state location and then from there out to different places within the state, or the state has an allocation plan and then they're shipped from a Moderna or Pfizer facility directly to the different recipients? Is that how it works?
Correct.
Okay.
Just a quick question on the slide you just were on. If we look at this data and then look at the new vaccine dashboard on the state site, I just want to make sure I understand how to track those two pieces of data. My understanding is that on the state site, that would be inclusive of these shots reflected here, plus what Mission HCA has administered, but not including long-term care. So on a daily basis, if we're trying to just keep an eye on this, that tells us, the state site shows us what Mission plus the health department have done, but it's probably not real-time data.
The state dashboard will show you what any provider other than the long-term care facility federal vaccinators have done. So I don't want to say just the hospital and the health department, because those enrolled providers are hopefully going to expand.
Right. Okay,
so when you see it on the dashboard, it's how many vaccines have been administered in Buncombe County, with the exception of those CVS, Walgreens, federal program long-term care facilities.
Okay, great. And as of today, those two providers would be the health department plus Mission. But moving forward, it'll be an expanding universe.
That's correct.
Okay, thanks for that clarification.
Yep. Correct.
So on January 14th, NCDHHS did recalibrate the guidance, and it did expand some of those healthcare workers, specifically dental hygienists and dentists. What is the plan to ensure that we're incorporating, specifically them and the others who have been recalibrated into 1A? And is that a place where we could potentially utilize that partnership with Mission so that we are ensuring that our frontline healthcare workers are also being vaccinated as well?
Yes, all of that has occurred. So with our 500 bump this week, we are providing appointments at 40 Cox for our healthcare workers who were not originally in the 1A iteration. That includes our dental community. They have received that those additional healthcare workers that were not in the initial 1A category have received notification from our medical director. And those appointments were opened at 40 Cox for our healthcare workers. Yes, they're full. And as far as working with our hospital, yes, we have been in talks with Mission Hospital about how they may be able to utilize some of their vaccine to also help provide vaccinations for that now expanded healthcare worker group. And I just wanted to give you an example of what it looks like. And so for just 1 week of planning or allocations, and this is just for this week of January 18th, that we had 2,845 appointments scheduled for this week. We actually have 2,285 vaccines scheduled for use that were in our inventory at that time, which means that we had 560 vaccine appointments that had to be covered by the next shipment, which is the one that came in today. So we are always working on a deficit as the next shipment comes in. And that is the nature of the week-to-week, getting only a week-to-week notification from the state about what your allocation will be. So we open up appointments ahead of time, at least 2 weeks out, for a minimum of 500, and that will likely increase over time as our projections increase. And then as we receive notification of our shipment, we increase those or add to those appointments so that it becomes much more than just 500 a week. It becomes 2,845. And then even doing that, we still always have a deficit until the next shipment comes in. And so we are always running from week to week until we do not have the amount of supply at this time that 1 whole week would be covered by 1 whole shipment. I'm just going to start with a little bit of the update and then turn it over to Fletch. So as I mentioned on the other slide, we received our first shipment on December 21st. In less than 24 hours of that shipment, we began vaccinating what used to be called Phase 1A on December 22nd. During that time, as we were at Irwin Hills doing the old 1A, we began planning how to increase our footprint and how to increase our capacity. And that's when we began the AB Tech operations that started January 11th with the initial capacity of 2,000 per week. And now exploring and getting ready to execute high school drive-throughs for second doses beginning January 25th. This will allow AB Tech to be our designated first dose site and increase its capacity so that all second doses would be able to be at another site with its own capacity. And Fletch will be talking much more about that. And vaccine rollout and scheduling first dose, we have heard our community, we have heard our leaders that scheduling is not the easiest thing in the world with limited doses. So launching this week, we will be launching a wait list. And an individual can call to be put on the wait list based on the phases. And currently we have phases 1 and 2 open of the current and revised vaccination plan. The wait list will open to others as the other phases open. So right now, the wait list would include those in phase 1 and 2, and as phase 3 opens, then you would be incorporated. And folks can call, when it's launched this week, folks will be able to call the 250-5000 or visit buncombeready.org to put themselves on the list or have a call member help them get on the list. They will be placed on the list, and then as we open appointments, our call team will call them and give them an appointment so they don't have to keep calling back. And those appointments, remember, are based on what phases we are in, right? So if you don't meet the criteria for phase 1 and 2, the wait list is meant to give appointments for those who are in those phases. So the pros here is that it eliminates the need to call in or to continually try to call in for an appointment. We hope that it will reduce the call volume and the stress, and you'll be placed on a wait list based on the current phases. Potential cons that we did want to make folks aware of, that it's still not a perfect system, so the new phases, as the new phases are rolled out, they will immediately be at the bottom of the list, but then what happens is that once a phase opens, then all the phases are kind of equal. And so if right now we're in phase 1 and 2, and when we open phase 3, they'll be at the bottom. But if someone else from phase 1 and 2 called in after the fact, they will be timestamped. So it's all a continuous timestamp. We do anticipate that folks might sign up for multiple lists and accept multiple appointments, which could hinder some of that ability to make. We do not want folks to make appointments with multiple providers and then become no-shows at VAX sites, because it is very important that people understand that we thaw out and get enough vaccine ready for that day. Wasting vaccine is not an option. And so we would just want that to be, we just want folks to be aware of that. We do anticipate that call volume and web traffic may still be high, particularly as new phases get implemented, but then that will come down as people can continually put themselves on that wait list. But the first day or so might be higher.
Stacy, I have a question.
Sure.
And thank you for working on this. I think this sounds really positive. So with the wait list process, that means when we get new shipments on Fridays, there won't be a call. Like basically the process is to get on the wait list. It's not
That's
to
right.
call when we get new doses that week. It's to get on the list, and you'll be scheduled, and we'll get to everyone as soon as we can based on the supplies increasing. That's the process.
That's correct. So when we open up those new appointments, you won't have to rush in to call. We'll work off that list that we have and call you and say, all right, we have appointments. Here's your first available appointment. All right, great. We've got you in there. So, but we do anticipate that as new phases open and folks want to get on that wait list because the new phase is open, we might still see a lot of call volume. We might see a lot of traffic on the website.
Understood.
Got I guess a vague question. I think this is the third or fourth time the phases have changed since
You
this
are
started.
correct. Yes,
Which it's been not even 30 days.
correct.
So, I guess I don't have a specific question for you, but what challenges might that bring a system like this for you? And
That's a wonderful question. And you are correct that it has changed multiple times in a short period of time. So the challenge, I will tell you, the most recent challenge has been with the state changing on notifying us that they were changing January 14th with an effective date January 15th, has been that we had already planned and scheduled appointments based on the previous iteration. And so there is an expectation when the Department of Health and Human Services or the governor says we're going into a new phase, that you will be able to incorporate them immediately. But that, at a local level, it's hard to turn that around to turn that on a dime.
of course.
And so, I think that has been one of the challenges that folks heard, hey, I'm in these new phases and I need to get a vaccine, yet we had already scheduled out all of our available vaccine at that time. So we try really hard to help people understand that yes, we are incorporating you, but we had given all of the appointments for our vaccine at this time. So we're going to work to try to find more vaccine and then open appointments for you. So that's where you saw the bump. We decided to use our bump this week from the Western North Carolina Collaborative specifically for our healthcare workers. And then now with the implementation of a wait list this week, that we'll be able to get through some of those. But that's one of the challenges, is that as soon as they change it at the state level, it's much harder to change it at a local level when you've put appointments out, you have folks getting ready to show up, and your VAX plan is in place.
And with the data collection, I guess, that goes into the wait list in terms of the data you're taking from an applicant or whatever we're calling them, is it your intention to collect enough data from that person to know what phase they qualify under?
Correct.
Okay.
That's right.
Despite
so without getting way into the weeds with it, yes, the answer is yes, that on the website, or if you were to call in, you'll be asked a few very simple questions that, are you over 65? Are you a healthcare worker? And if the answers are yes, then you clearly meet the phases. If you are, under 65 and not a healthcare worker, then you don't meet the phases right now, and you'll have to wait until the wait list for phase 3 opens up if you're a frontline essential worker. So yes, there's some screening questions.
Thank you.
And so just what's the plan for the wait list? And so we are already training and getting our ready team, and they'll be notified and queued up for calls. The website will be updated to reflect the current phases. I just sort of mentioned that on the website, we call them the big buttons. There'll be big buttons that say, are you a healthcare worker? Are you 65 or older? There will be a button for folks who are neither one of those things so that they can understand where they are in the process. And then the phone tree message will be updated to reflect that wait list option as well. Mass notifications will be sent out when when we enter a new phase and the wait list is open for that new phase. And the wait list, again, you can get on the wait list when it's launched through Buncombe County, buncombeready.org, or by calling 250-5000.
So you can get on the wait list by going to the website and clicking on a button.
Yes.
Or placing the phone call.
Correct.
Either option.
Correct.
Okay.
We still needed both options
Sure.
for folks.
Yeah, makes sense.
And will the phones be answered 8 to 5?
Correct.
Stacy, you might just make sure they know it's not until tomorrow.
Right. Later this week. Later this week. Yes, please be patient as we are building this, and we want to be sure that it is as right as it can be for folks to be able to use it as most effectively. So you will see notification coming out when it's ready for folks to be able to call. So vaccine rollout for the second doses, just quickly, that beginning January 25th, second doses will be provided at our drive-through sites at designated high schools. I want to give a big shout out to public health, emergency management, fire departments, and our Buncombe County schools for all their hard work on getting our drive-through sites up and ready. And for those receiving their first dose prior to January 21st, so Commissioner Whitesides will receive a call from the team with details on your date, your location, and what window of time for your second dose. And so we'll be making those calls later this week and early into next week so that folks who received, so our group that was in the iteration called Phase 1B Group 1, who got their vaccines on January 11th, will get all their information about how to get their second dose. For those who are receiving their first dose at AB Tech beginning January 21st, they will receive a card that says your second dose is on this date, at this location, at this time. Fletch is going to go over more of that with you. I just want to put that out as part of the update. And then I'm going to give it to Fletch to go through more of that.
So Brownie, can you summarize that again? These are the points we want to make sure the public gets, and we talked about making sure that we pause and summarize that. So would you summarize that point again on the second dose card? It's like a doctor's appointment card that you'll get when you leave.
So let me see if I got this right.
Put it back up on the
So the
screen
AB
for you.
Tech site is going to be dedicated to administering first shots, first vaccines, and we're going to open up a high school site as a drive-through location for people 75 or older, now 65 plus, who've already received one vaccine to receive their second vaccine. So we'll have a dedicated second vaccination site, and AB Tech will be reserved for first vaccinations to keep that system as clean as possible, and in terms of intermingling first vaccines and second vaccinations for folks. There's going to be a wait list. It's not ready to go yet. It's going to be ready to go later this week. And folks can call or go to our website to get on the wait list, and then the county will follow up with them to schedule an appointment as our vaccine supplies increase and we have enough shots to give to additional people. So more details than that, but I think those were kind of some of the important updates I've heard.
Great.
Oh, sorry. And
I just wanted to add that being able to separate the first and second dose in two different sites allows us to increase that capacity and footprint at AB Tech, and then work up to increasing that footprint at our drive-through sites, which Fletch will talk about shortly. So this, in anticipation of lots of vaccine coming to this community, we are trying to make sure that we have the footprint for that and that we practice that each time. So each week we are increasing those doses as we advocate for more, and hopefully we'll just get more in our regular shipment.
And this is kind of an in the weeds kind of detail, but in terms of people getting a follow-up phone call, that'll probably be from a human being,
Yes.
or as opposed to recordings. Like, it'll actually be someone calling to talk to them and talk through the scheduling of their second vaccines.
I do believe it's going to be an actual human, and that's for folks who receive their vaccine before January 21st.
Great, great. All right, thank you very much, Stacey. Appreciate it.
Good afternoon. I'm going to roll into the vaccine operations, but I did want to address a couple of the questions earlier from an operations standpoint. One was about with the wait list. I just want to make it clear, we're trying to set expectations for you guys, because a lot of times the responses we see from the public, you guys see as well. So we do know, with the wait list, once that wait list gets to tens of thousands of people, theoretically with our input of vaccines, people are going to be scheduled out to February to March to April. So just make sure you guys are aware there's going to be some consternation from that. And the other part for Commissioner Edwards about your question earlier from dentists, and Commissioner Sloan, your question about how those changing phases affects us in operations. I think a really good example is probably what prompted your question, is from the dental community. We have a group who initially wasn't in 1A, then was in 1A1, and then all of a sudden with a new phase, now they're in 1. So we've told them they're in, they're out, they're back in, and now they're in, but we've already allocated this week's worth of vaccines. So that's a really good example. So now we have a community who's been jerked back and forth because of federal and state guidance, who we've already allocated vaccines, who probably are in high demand, and we're doing the best we can with that extra bump to compensate for that. But it all comes down, again, to a supply and demand issue. We've got thousands of people in the dental field in their offices in town, and we have 500 allotted to a health community group. So it's just competition basically at this point for who gets those first 500 doses, and we're working as hard as we can to get them spaces as they become available. So I'm going to go into a VAX operations overview. So at the AB Tech, we're receiving overwhelmingly positive feedback from people and clients who pass through there. On a week-to-week basis, we are now administering 100% of our first dose weekly allotments on that Wednesday schedule. Today's throughput, where we're seeing about 600 at the VAX site. By the time I left, our average entry, the vaccination time, is 12 minutes. That means when somebody arrives, from the time they walk into the door to the moment the injection's going in their arm, is averaging about 12 minutes. And we think that's even a little slower than our average for the general public because of the age group we're focusing on now. In addition to that 600 at fixed sites, we're also doing about 70 mobile VAX site operations today as well. And I also want to point out, Stacey kind of alluded to this, but we're currently vaccinating over 1,000 more a week than is our standard allotment from the state. Our standard allotment from the state is only 975 of Pfizer. We're getting that 500 bump from the Western North Carolina Collaborative that Stacey talked about, and for the last couple of weeks, we're getting a bump of 975 from Mission. So that's public health going out and advocating to the state and local partners that we need more vaccines because we're ready to give them out.
Fletch, that's a one-time 975 from HCA, not weekly, or
it's a week to week right now. So we received it last week, and we just worked with them to receive it again this week.
Oh wow, okay.
So that's us with our partnership with Mission System, Dr. Hathaway, advocating and saying you have doses, we're ready to give them out, share those with us.
And it should be here by the end of the week.
Yeah, and this week should be here by the end of the week, and that's going to go to our appointments for the following week. So our expansion of vaccine operations, as of Monday, our fixed site AB Tech increased our throughput there from 2,000 to 4,000. Today is the highest throughput we've had so far, and what we're seeing is that we're even more efficient than we were calculated on paper. And so what we thought was 4,000 a week. From what we've seen, I think we can easily do 1,000 a day there for a total of 5,000 a week, and potentially once we see those numbers, I have a pretty good feeling we can start pushing 1,200 a day through the AB Tech site once we go into this new model. and we have the vaccine on hand, of course. So we're shifting models beginning. We started some of that this week by removing some of our administrative burden from pre-vaccine to post-vaccine. But fundamentally, what changes for us next week is that we're removing all second doses from the AB Tech site and moving them to vehicle-based sites at Reynolds High School initially. So what that allows us to do is to focus solely on first doses at AB Tech. There's a different administrative burden for first doses versus second doses. And there's it just removes a lot of complications from having to have multiple vaccines, multiple doses at the same site for scheduling purposes. So those second doses will start being administered at a vehicle-based site at Reynolds High School. Vehicle-based works really well for this because there's much less of administrative burden. Basically, if they already have their VAX card, they're fast-tracked right through. They never have to get out of the car. Very minimum paperwork. We're planning process now. We're looking at having action plans for 3 additional high schools, and with also the option of running 2 simultaneously. So when we're at full capacity of those schools, we think each one should have a throughput of roughly 5,000 a week. So between the 5,000 plus at our fixed site and the 5,000 at those vehicle-based sites, with one that gives us a max throughput weekly from public health of 10,000 or potentially 15,000 if we have 2 sites in a hybrid model. There are some planning assumptions here. The first is that these projected throughputs are based on what we're seeing so far at current operations. As we scale up, those mathematics might not always work out. We did see, fortunately this time, that we're more efficient than we thought on paper. But, with vehicle-based, it may be less efficient than we're planning, but we won't really know until we get those in full swing. And the other assumption is that at some point, right now, we're having these conversations about first and second dose. At some point, that only becomes relevant at an individual level. And what that means is at some point, we have enough supply on hand where we just open up a site. And then you come, and whether it's your first dose or second dose, you go through, you just come to a site. But right now, with such limited resources, we have to be very specific about what we allocate for first dose and second dose. So eventually, it won't be a first dose site and a second dose site. It will essentially be a hybrid site. So this is stemming from some of the conversations we had last week. This is our public health burden to get us to 70% vaccinated in the community. There are some notional assumptions here that we know aren't necessarily true or will change, but this is a good way to kind of conceptualize what we have to do for the community in response to, I think, some of the questions and conversation we had last week. So this is assuming that public health is the only provider in the community. So this is before we account for any additional providers, which we know and hope more will come online. This isn't accounting for the mission hospital system. This is the assumption that as much as we could push out will be supplied from the state. And this is also the assumption that all the vaccines we're going to be working with have the 2-dose regimen, meaning we have a 3-week or 4-week period between first and second dose. So knowing our population from the latest census data at 261,000, and we take 70% of that, which is our goal, and then double that for 2 doses. So we have to put through 365,600 doses. So if you, on the far left, you see if we have those 2 sites open just for public health, doing 10,000 a week, 40,000 a month, that takes us 37 weeks to get to 70%, assuming there's that appetite in the community. So 9.5 months. If we have those 3 sites functional, which gives us notionally 15,000 a week for 60,000 a month, that puts us at 6.5 months. And then this last slide is the reality based on our current allotments, where we're getting $1,475 a week with that's from the state, not accounting the mission transfer, which is $5,900 a month, which puts us at 60 months to completion. And we know that's going to change. We know we're going to start seeing more vaccine and more providers come online. But from what we're seeing right now, just for perspective, this is the hurdle we're seeing. And then lastly, I want to talk about transfer to providers. So we're increasing our capacity so we can double and triple our current stance. But we don't want to wait till we reach our current capacity before we consider transferring additional doses to providers. And here are some reasons why. One, when we have these providers in the community, we know they're a trusted source. they're already working with some unique populations or specified groups in the community, and they have those established relationships. And with those communities, because of those trust factor and they already know the networks, a lot of times they're going to do that better than public health. We're looking at this through an equity lens. So if we give it to providers, it means more locations, geographically dispersed throughout the community. It means different hours, and it means more opportunities for community, just like flu clinics. You could go to a supermarket, a pharmacy, some local provider, and get flu. It's not just all at public health. Low distribution. So we have theoretical capacities, but we don't want to get to the point where we don't have providers online when we find out what the capacity is. So if we bring them online before that point, it allows us to achieve our true capacity and still have others online to assist us. And finally, it gives a good ramp-up time for providers. Doing max vaccination is a pretty complex operation. So if we start them early, it gives them time to learn the process, train their staff, and go through their own process improvement. And then we can verify as we pass the providers that they do have the appetite and the capacity to push what we're given, and then we can slowly ramp them up at a local level. I think that's the end of our slide. Do you have any questions for the vaccine expansion?
So a question about, well, if you're a general practitioner's office, that office needs to be registered or approved through the state to give out the vaccine. But I think what I'm hearing you say is that we would be responsible for supplying the shipment to them.
So currently, there's only a handful of providers approved in Buncombe County. We're hoping very quickly more of those providers are approved by the state. What we don't know yet is even once they're approved, will the state be giving them direct allotments, or will they be giving allotments to us and Mission, who then have to transfer to them? I don't think we have a clear picture on that process yet. And that's part of our hurdles we see in our planning process, is we just don't know that.
It seems like something we should or could find out. Is that something that the board could assist you with, or do you expect to find that answer soon? Or
So the state had a plan for bringing on providers. Their initial plan was hospitals and health departments. They have slowly brought on other providers. Here out in Western North Carolina, we do have a couple who have been brought on board, and with the Western North Carolina Collaborative, one did receive, that was Blue Ridge, did receive a vaccine transfer for them to be able to start doing it. As others come on board, the hope is that they will receive their vaccine allotments directly from the state, but the state has said to be determined, because they only have for the state, they only have a small amount. So they may divvy it up to counties or hospitals, allow us to figure out, all right, how much can we do? Do we have a little bit extra that we can transfer, whether it's a health department or a hospital? And so we talk about that almost weekly with the state, about firming up that plan and fast tracking those providers, particularly as we think about what Fletch was saying, when we think about flu and those types of, you're going to be able to get, you get a flu shot at your pharmacy, at your medical home, and particularly with our populations who are 65 and 75 and above, they have medical homes, they have trusted places they like to get their medical care, that they may feel more familiar with that. And so we want those providers to have access, and we want those providers to be practicing mass vaccination, or at least their vaccine protocols. But without enough vaccine, it's kind of hard. So what's been happening so far is other providers getting transfers of small doses, small amounts, or getting a small allocation straight from the state.
thank you.
As we think about who will be providing vaccines down the road, do we have any sense of what HCA's plan is? I know they are a closed pod, meaning they would just vaccinate their employees, and then do we know whether they would plan to stop at that point, or whether they would continue to operate as a provider of vaccines at the community level?
I'm not aware of their long-term plans. I can tell you what we've been talking through most recently.
Great.
So in the first phases, they were dedicated to their to those phase 1A healthcare workers critical to COVID care, which was most certainly their charge. And then as time has gone on, as you heard tonight or today, they have been talking with us about transferring more of their vaccine to the community. So we received one transfer of 975 last week. We are set to, the transfer was initiated today. It usually takes a couple of days, so we are likely to see that physical transfer, meaning it comes into our possession by the end of the week. Mission has been really open about discussing that with us, particularly if they have vaccine that they can give, being able to give that to us. And we are discussing with Mission too about their possibility of not just in a closed pod, but how can they also help us with our healthcare workers, particularly with groups, as you heard Fletch sort of describe, that, you know, we're in, we're out, we're in, like how do we reach this group that clearly now in this more simple vaccination prioritization plan are a priority in phase 1. And so we're discussing that. We have our weekly calls on Wednesday, so I imagine I'll hear more tomorrow about what their plan is to help go out into the community. So,
Okay, thank you.
Yeah.
The follow-up on that quickly is just, it seems like, following up on Parker's question, where there is a scenario where we could actually be the local distributor to various satellite sites, and then also looking at scenario A and B on this last slide. Any way you look at it, the county's playing a central key leadership role.
Correct.
In how this is actually going to move. And in fact, probably the largest leadership role in our county as we think about the entities that exist here. So
And
that's sort of our charge right now, is to figure out how we step into that fully. And y'all, thank you. This is a really crisp, accessible presentation of, I know there's a tremendous amount of data and logistics to distill down to something that we can digest and the community can. So thank you for the hard work and the sort of, I'm guessing a lot of work over the weekend that went into getting ready for today. So appreciated.
Most appreciated. Thank you.
Does the collaborative include both the medical community entities that are interested in this, as well as some of the like pharmacies, private sector entities? Are they all in the kind of in this conversation?
In the Western North Carolina Collaborative?
Yes. Okay.
So right now it is, it includes health departments, community health centers, and hospitals in the area. And so I should say, I'm sorry that Dr. Hathaway couldn't be with us, and I won't go into great detail because I do not know it. But in addition to transferring vaccine to us here in Buncombe County at the health department, Mission also transferred it to other groups within the collaborative. So it's not just here in our community, but Mission is seeing the importance of getting it out into the region. So right now that collaborative includes health departments, community health centers, and the hospitals. And each, because geographically we're a bit different than the triad and triangle, and that regional approach allows us to be very, to customize what we need to do for our communities. And so you might have heard in the I think it was the triad or the triangle, very large mass vaccination sites like in large municipalities, urban centers. Out here, we decided to do that a little different, knowing that geography, quite literally, the geography can be somewhat of a challenge to get to one place or to another for folks, and that being able to get vaccine in your community was a much bigger priority for us. And so we were able to work with the state to get additional doses for counties like Madison, and to be able to transfer to community health centers to start trying out their process, and also to get additional doses for our own county to be able to expand our appointments, knowing how large our population is.
And so the private, like the private pharmacies, they're not part of the collaborative.
Not
I
at
think
this
we've all
point.
kind of heard kind of anecdotally that some of them are applying to be part of the get certified as well to be able to distribute the vaccines to the general public as the vaccine supplies increase. Is there any way that we could kind of find out what their plans are too? I mean, of course, they have to get approved by the state, but
Correct.
But I'm sure within their organizations, they're thinking about, assuming we're approved, here's what we think we could probably do at our different, retail locations and things like that. But I mean, it's potentially a significant capacity as well, right? I mean, I think there's like a dozen Ingalls and then like another dozen CVS's and Walgreens. So, maybe 25 or 30 sites potentially that could be sites. So how do we ascertain what they're thinking so it can be kind of, part of the overall picture of what community capacity could look like?
So I'm going to step back just a second and say that, yes, in the North Carolina Department of Health and Human Services plan, they started with hospitals and health departments, and then the next wave is FQHCs, community health centers, and then it's my understanding that large retail pharmacies are next. And so many of those large retail pharmacies have already started creating their plans, they're putting up their websites, they're getting themselves ready in anticipation. And so I do not, at this point, have a very good picture of what that landscape looks like locally, only that they have not been onboarded yet, and are not receiving vaccine yet, as far as the Department of Health and Human Services plan is, but that our next wave will be those community health centers, so that, as Fletch mentioned, that they are reaching populations that we are eager to serve, either through our historically marginalized populations or our equity lens, or create medical homes where this can happen too. And then the plan is to go into the large retail pharmacies. I can ask the state if they have better indications about when that will happen and who they've been talking to and what their plan is, but that has not been broached in great detail right now. But to your point, yes, the assumption is that they will be brought on board and will provide much opportunity.
Either through their own allocations, or counties like Buncombe can get a large supply and then distribute a meaningful percentage out to some of those kind of facilities.
Yes, the hope is by the time we get to that level of provider onboarding that those providers will be receiving direct allocations from the state. If not, yes, if those allocations are sufficient and they're coming to the county, then we would be able to transfer if they were approved through the state as a CVMS COVID enrolled provider.
I have another question. I'm really pleased to hear about the equity work in particular, and I think with Winches and Appalachian Health hopefully coming online soon, that will start to address some of those challenges. And I certainly appreciate the work that is being done in other languages. However, my concern is what other types of relationships are being built to specifically reach our non-native English speakers, as we know that's a significant portion of the residents of Buncombe County. I know these are done in both language, in multiple languages. Videos have been done in other languages. 8 to 5, however, is a prime time for that particular population of our community to be working, and they don't necessarily have access to watching these at a later date. And the relationships that they have in their community is where they tend to get their information, and building those relationships are really important for them to trust the government, Buncombe County government in particular, to issue vaccinations. So can you speak a little more in depth, specifically in regards to non-native English speakers?
And so part of what we've done throughout the entire COVID response is to work through those community leaders, both through our operations piece, but also through the joint information communications piece, that our communication team works with those key stakeholders within communities to get that message out. So the way we say it as far as health and human services, to craft that in a way that is culturally appropriate and resonates with other groups. And so our communications team continually works with those community stakeholders to get that message out about what are the things that are happening, when are they happening, and how can you access them. We continue to work, particularly with vaccine, with community health workers that are in the community, and have reached out. Our equity and our communications team have worked with not only our community health workers that are in Buncombe County, but again, those community stakeholders who have close ties to help folks understand how they can get vaccine, what are the options for them, what phases they are in. That work continues. Yeah.
Just want to point out that we're also, we've provided interviews and we'll continue to provide interviews directly to JMPro, which is the largest Spanish language-based Latinx media platform in the community. And also for 6 or 7 months now, every messaging coming from public health, whether it's at our community briefings or this briefing right now, is being live cast in Spanish on our Facebook channels. So we're constantly striving to make sure we reach our non-English language speakers.
And please note, it's not a criticism. I appreciate what is being done and has been done and how it's being looked towards in the future. I'm concerned that that is a target population that is not tuned in to these briefings and such during the 8 to 5 workday, and how we continue to reach them when they are not at work.
You know, a question I have is we look ahead, and hopefully we've got a lot of vaccine. We have a lot of different organizations in the community giving vaccines. Are you going to have any way for these organizations to talk to each other? Because what happens if Al Whiteside said, well, we got 10 locations, or, you know, other than the county, I'm going to sign up with all 10 and see who I can get to first. But how are you going to know that, hey, this old man's already gotten his shot, and he's got 8 more locations tied up? But, you know, how do you look ahead to that?
So I feel like you are inside my brain space already. So I can tell you for the actual vaccine administration piece, all vaccine providers in North Carolina must be enrolled through the COVID vaccine management system. That's the thing we call CVMS. When you get your vaccine, you have to be put into that CVMS system. So if you got your first vaccine with us, but then you moved to another county or whatever happened and you had to go somewhere else, they will see you in that CVMS and know that you got your first dose of whatever kind, Moderna or Pfizer, on this date at this time, and that you are eligible for your second dose. So that's how the vaccine piece works. When it comes to things like, as I mentioned with the wait list, that is a great concern to me that folks might be on wait lists everywhere. And some of that will work itself out as we call people back and say, we have an appointment available for you. And they may say, as other providers get on board, oh, I'm getting mine at CVS, or I'm getting mine with my FQHC. And we'll just mark through, we'll check them off the list and move on to the next person. But as far as your vaccine administration, that is precisely the reason the CVMS system is supposed to be in place, and you must be enrolled not only as a provider in that to be able to give out vaccine, but as a recipient, you are logged into that system.
I have maybe one last question. Just going to this slide about the public health burden, 70%. The slide that Fletch went over. I think it's an important slide. It kind of shows the order of magnitude. That this kind of whole initiative ultimately is going to have to encompass for a county with more than 250,000 people and people needing to get 2 vaccines. It's a lot. And so you've got these 3 different scenarios of kind of the kind of status quo, very limited vaccine supply. If that doesn't change, which it will, but if it didn't, it would be a very long haul. And then looking at if we had the ability to get 10,000 a week or 15,000 a week, the relative time frames to get to the 70% goal under those scenarios. So, Fletch, is the right way to interpret this? We've talked about kind of what the county's plans are. There's a lot of uncertainty about kind of exactly how the private sector and other partners are going to play out yet, but we expect that to be an increasingly robust set of additional providers. But just kind of theoretically, if no one else were doing anything, these charts kind of show like here's how many do need to get administered to get to these different goals on different timelines. And while we're looking forward to kind of bringing out the full capabilities of the community through these partnerships, and that's the basic intent. If the county had to do it, based on the kind of logistics that you've been talking about, it sounds like the county could do it. We don't think that's the ideal. We think there's a better way to do it. But if we had to, there really is kind of a pathway to doing that if, for some reason, we were in that scenario. Correct.
Not ideal and frankly not anticipated, but part of my role as preparedness director is these worst case scenario plannings. And so if we were getting the vaccine, that's the long tenet in this poll. If we had the vaccine to that rate, we could, over the 6.5 months, we could do it, or over the 9.5 months, depending on the rate.
Right. Okay.
But again, we fully anticipate other providers coming online, larger shipments of vaccine, Mission being able to pivot for and assist us as well.
Okay, great. Well, that's fantastic and very encouraging. This may be a question more for Avril than for Fletch. I'll just ask and anybody can field it. So are there other things that the staff need from the commission in order to make planning for assuring that we could, if the supply chain is out there to do it, that we could achieve the 6.5 month time frame in terms of the 70% goal?
Yes, sir, and we actually have that for the 5 o'clock conversation, where
Okay.
you can take action, but we are requesting some budget amendments at 5 o'clock.
Okay, perfect.
Yes.
Other questions, commissioners?
I have one more question, just, could you update us sort of on the status of the EOC at this point, and whether you all envision that ramping back up relative to any of these scenarios?
We do, if this burden plays out a little bit where, we're not getting the assistance we anticipate from community. But I think we'll also be speaking to this a little bit at 5 o'clock. But I think when we're looking at multiple sites where we have not just AB Tech, but 1 or 2 vehicle-based sites, we do need to increase that footprint a little bit. We have essentially an incident management team, so a small component of a true EOC for VAX operations. But as we're assessing and going forward, we're constantly considering having to expand that.
Thank you.
All right. Stacy and Fletch, thank you so much. We appreciate you. Appreciate all the work going into this from everybody on your teams. So great job.
Yes, thank you. Thank you for what you're doing.
All right. Next up